Hello, I'd like to introduce myself. I'm Julian Bedford of Instinctive. We're the Navilas distributor for ODOS in the United Kingdom and Ireland. But more particularly, I'd like to introduce consultant surgeon, Mr. Mark Costen. He is the joint clinical lead for ophthalmology at Hull Teaching Hospitals Trust. Mark is also the senior tutor for the Hull Medical School and a fellowship examiner for the Royal College of Ophthalmologists. He specializes in VR and cataract surgery, and Mark has kindly volunteered to give his time today to present in the winter webinar series for Navilas. Mark, could you explain how your decision to include Navilas technology at Hull and East Yorkshire Eye Hospital came about?
Yeah, thanks, Julian. So we were looking to acquire a second laser in our busy department, and I'd seen several demonstrations of the Navilas and its capabilities previously, and so we were looking to try and just really expand our laser equipment, our laser service with some of the newer technology. So it really was just very much at that point getting a second laser. And we trialed the Navilas system, and it became very apparent early on that there were some significant advantages in terms of speed of application and ease of application, whereas well, obviously we're all aware of some barriers sometimes with some of the slit lamp laser techniques and patient tolerability, and that it became very apparent during the trial that there were some significant advantages. So yeah, we went ahead and were able to acquire a Navilas system.
Okay, so did you have particular uses in mind in advance of acquiring, or you had a definite plan in how you'd use Navilas at the hospital?
Yeah, good question. So we were just coming out of COVID, diabetic screening, obviously, along with many parts of ophthalmic care had obviously been impacted quite significantly. So we had a number of R3 active retinopathy patients on the books, some of whom through COVID they'd had delayed treatment. One of the key things for us was to have effective, quick access to pan-retinal photocoagulation fairly urgently for some of these patients to try and prevent them developing advanced proliferative diabetic retinopathy and requiring surgery. So yeah, what we needed a reliable laser that we could use for fairly high, sort of high volume capacity to get through our active R3 patients.
When you're treating this high volume of patients, do you see any patient benefits that perhaps aren't there or weren't there in the same significance compared to existing technology?
Patients don't like laser very much. They don't see any benefit from it. It's uncomfortable quite often. And so we have a reasonably high DNA rate for some of the laser clinics. And these are patients have had traditional slit lamp laser. And so it's been very difficult to actually complete a course of treatment for some of these patients. And then one of the first things we noticed was the patients, comments such as, "Gosh, this is nothing like the other laser," or, "This was so much better." And we found that patient tolerance was vastly improved with a Navilas. And whether it's due to obviously probably partly due to the infrared background illumination is much more patient friendly. The treatment's quick. And yeah, generally, we really positive feedback from patients.
So in terms of patient tolerance then, is there any difference to the way Navilas is delivered, how you deliver treatments, given that it doesn't have those set of oculars on a slit lamp?
So yeah, and that's obviously there is a learning curve with the different treatment setup, and so we've obviously had to have some dedicated training for doctors like myself. We were brought up on slit lamp laser, but as we get older, I find those sort of slit lamp therapies more and more uncomfortable on the neck. and I know a number of colleagues have similar issues. And what was very apparent from the Navilas system, because it works in a totally different way, and you're not actually leaning over the laser delivery system while you're treating. It's much more comfortable for the operator as well as the patient. But because of that, I know we've spoken before, Julian, when you were sort of you were demonstrating it. You've got to imagine yourselves more as an imaging technician, because you're taking photographs and you're treating based on that. And once you get your head around that, and people, we're all used to using iPads and digital technology, pick that up incredibly quickly, and it's a refreshing change. So yes, there is a learning curve, and you have to have some training, but my experience of sort of cascade training this to other clinicians is very, very positive.
Did trainees and juniors use Navilas? You've mentioned other colleagues and the need for training supervision. What are the differences there compared to slit lamp lasers?
So I think that probably the uptake is probably just as quick for both, and as well as more experienced laser operators who've been lasering for a long time. But once you know the principles of what you're doing with the laser treatment, you actually learn it incredibly quickly, which obviously gives the potential advantage of being able to train allied health professionals, because with the safety parameters of the Navilas and being able to put exclusion zones and map treatment accurately, I can't see any reason really why that laser application cannot be performed by other members of staff, and that would help hugely from capacity issues in busy departments. Allied health professionals have been doing YAG laser, peripheral iridotomies, capsulotomies quite extensively, but I think the realm of retinal laser has been relatively protected. And obviously clinicians are busy, they've got a lot of demands on their time. I think I see a definite role for allied health professionals taking this on and doing some of those pan-retinal treatments, because I think it's eminently teachable. I said, if you've got the safety features and the potential for network supervision as well remotely, just adds to that ability to be able to broaden its use. And make those laser clinics much more efficient.
And now, as we have some treatments and case examples you prepared for us, would you mind talking us through those, please?
Yeah. So basically, this is a patient this is his first treatment in this eye. So I've just taken the initial shot of the posterior pole, and then this is where I do a little bit of titration. So I've just mapped a few areas around the macula just for those initial shots to get the initial power, and just check patient tolerance, really. Gets the patient used to the laser. So these are fairly small areas of treatment. And as I said, I can adjust the power as needed as I'm working around this area. And it's quite easy to gauge how well the patient's tolerating the treatment at this stage.
And this patient had multiple treatments in his fellow eye.
Yeah, that's right, Julian. So this patient had multiple small sessions of pattern laser in the other eye, different system, but did struggle with it. So we had to keep coming back, which in the ophthalmology clinic, that is an issue, because with capacity issues, there's quite a high risk of patients being delayed. Thankfully, he wasn't, and we did manage to complete his treatment, but it took a long period of time. What was quite apparent here, and you can tell I'm able to just continue treating. He tolerated it remarkably well, and I'm quite sure that's the comfort feature, the infrared background illumination there, that it's just much kinder to the patient. And even though you're doing fairly intense bursts of laser, they still seem to tolerate that much better than the background illumination with some other systems. So I'm just going over, these are areas where I'm just doing titration on the move, really. They obviously wasn't quite happy with the burn intensity, but it's still relatively quick, and I'm just adjusting the power as I'm moving around. So then I move around. So I tend to quite like to do the inferior areas early on. Possibly, I think it's partly out of habit. I think as a retinal surgeon, because obviously patients, they do get vitreous hemorrhage. It often collects inferiorly and makes it much more difficult to treat. So I'm quite an early inferior retina treater. So, and here I'm just mapping out quite a large area now. So I know he's tolerating it quite well. So I'm emboldened to try and map a large area and see how well he just copes with that. And as you see, I'm just applying quite a large area of treatment fairly quickly. What's quite noticeable is I'm really not having to pause. The only time that I really needed to pause was as I went and mapped and treated another area of retina. So I was able to actually do fairly continuous treatment.
In total, I think the treatment total number of shots, just slightly obscured at the top of the screen there, is around about 1,300 for this single sitting.
Yeah.
In just a few minutes.
And as you can see, the really very little movement and very little pause in between. So the patient's tolerating it incredibly well.
You made a comment, you've alluded to it already. Most frequent reason why patients don't attend in clinic is because of pain from previous laser?
It's a common reason. I wouldn't say it's, I mean, quite often these patients have got multiple comorbidities. They have other clinics to attend to. Sometimes they have dialysis sessions. They're clinic weary patients. So there are probably multiple reasons why they DNA, but intolerance to laser, it's an important one. And we've had several patients that have been frequent DNAers and caused us a lot of worry, have started now to come for laser because they're having the Navilas, which is really, really, really encouraging. Sometimes the more peripheral treatments the patients can be a little bit more aware of. So I'm titrating downwards a little bit here because there are one or two areas of slightly higher intensity burns. So I do titrate a little bit as I'm going around. I don't just stick the power at the same and keep going. I do modify it as needed. But it's very quick and easy to do. I mean, the control's quite near and accessible, so it's quite easy to do on the go.
Are any of those patients that aren't attending, are they hangovers from the COVID era?
Yeah, some of them are, absolutely. Some of them are. We had a run of very, very aggressive diabetics during COVID and immediately post-COVID, and that because the screening had been suspended for a while, and that these patients were delayed in the system for other reasons. So, some of them had treatment, but they hadn't had enough PRP. There are a whole load of reasons, and obviously we weren't doing face-to-face slit lamp PRP at the time. We were having to do them in theatre as well. So there are multiple challenges, but anything that enables us to get PRP more timely and more complete is going to be a good thing. So we're really keen to get as many patients through this pathway as we can.
Certainly the eye movement there seems to be pretty minimal.
Yeah.
The patient's not reacting backwards.
Yeah, and I think his comment at the end of it was said it all really. That was just so much better than the last time, and yet we've probably done a huge deal more laser than he's had the last time. So it's the treatment speaks for itself really. This is a very ischemic retina. I was more keen to just get blanket coverage of laser on, basically to get good coverage. I was more concerned about this chap becoming increasingly rubio. He already had some rubiosis and raised pressure. So the goal here is to get as much PRP in place as possible.
Perhaps not the easiest patient to treat, but not atypical by any means, because this chap was in a wheelchair.
No, we've got a lot of these. This is becoming more common. So again, very little eye movement. Patient tolerating the treatment extremely well.
You've just taken a photo there to check the uptake.
Yeah. So I'm just doing regular photos. I've had the odd instance where I've sort of just the ability of the Navilas to register with the infrared temporarily impaired. So I just tend to switch back to color mode then, and immediately the map will appear and you can carry on treating. So that happens now and then. you can toggle between the two quite easily. And sometimes if you've got an area that's difficult to visualize, it's really nice to be able to just switch back to the color mode temporarily. And you can obviously gauge your treatment effect as well at the same time. With these patients is under treatment. The problem is the hemorrhage and the swelling have limited the amount of PRP uptake up to this point. And that really the only thing you really just got to get decent treatment on there and fairly quickly. I mean, obviously there's there's obviously patient variability. Some patients would find that more difficult. You gauge the patient quite quickly, I think, as to how much they can cope with. But I'm sure the fact that there are brief pauses in between the different treatment bursts where there isn't that background illumination, I think that it helps. It shows that that background illumination is a very strong factor in tolerance for the laser, as much as the laser itself. So I think we're getting near to the end of this particular treatment. Again, managed to get quite a sizable number of burns on in one setting, which, if you're worried about patient compliance and obviously the ability to recall the patient again quickly, that's a really important factor. And I do think, obviously I was saying to yourself, Julian, that I think it's the paperwork, it's the admin around the lasering that's taking the time. That the actual laser itself is actually pretty rapid, and so it does lend itself to probably slightly higher volume lists, which is always going to be a good thing.
That's very good to know. Two very successful treatments there, it looks like, and we appreciate your willingness to contribute to these webinars and share your experience with Navilas. Thank you to the patients as well. And perhaps in the future, we'll look forward to some more contributions from you.
Yeah, thank you, Julian. Thanks for all your support.
Not at all. Thank you, Mark.